Welcome to the e-learning module on ophthalmic anatomy that forms part of Section 3, Basic Principles of Ophthalmic Anesthesia. The key learning points of this module are to gain an understanding of the anatomy of the eye that is relevant to anesthetic practice. We will look specifically at the surface anatomy of the eye and the bony orbit, the orbital contents, and then the eye itself. At each stage, we will address some of the key clinical items relating to each area. A good understanding of anatomy is essential to the anesthesiologist for all areas of our practice. Sound anatomical knowledge supports our examination of the patient, the formation of a diagnosis, the accurate communication of our findings to both the patient and our other medical colleagues. It is essential if we are to administer anesthetic blocks more effectively and safely, and it allows us to understand potential complications of our practice. Overall, it makes us better anesthesia providers. First, we will look at the surface anatomy of the eye and then talk about the bony orbit. Being able to describe the surface landmarks of the eye is essential. The space between 1 and 2 is called the palpebral fissure. In simple terms, it is the opening between the eyelids. In adult humans, this measures about 10 millimeters vertically and 30 millimeters horizontally. 3 is the lateral angle of the eye. 4 is the medial angle of the eye. 5 is the lacrimal caruncle, and this is a key landmark for the medial component of peribulbar blocks that will be discussed in a later module. 6 is the limbus. This is the border of the cornea and the sclera, the white part of the eye. The corneal limbus contains the fibrovascular ridges known as the palisades of Vogt. These contain the stem cells that are essential for the corneal epithelial surface. The limbus is also the origin of the conjunctiva and Tenon's fascia, and at this point these two layers are fused together. 7 is the iris, or the coloured part of the eye. 8 is the pupil. 9 is the eyelid. 10 is the conjunctiva. And 11 is the semilunar fold. This functions during movement of the eye to help maintain tear drainage, and without this fold, the conjunctiva would attach directly to the eyeball, which would restrict its movement. The bony orbit is shaped like a cone, with its apex posteriorly and its base anteriorly. It has a roof, floor, and side walls composed of bone. There are fissures and canals posteriorly that allow nerves and blood vessels to enter the orbit. It contains the globe, the extraocular muscles, nerves, blood vessels, lacrimal apparatus, and adipose tissue, and we will discuss these items more later in this module. And now a couple of clinical notes on the ocular surface. When you examine your patient, look for signs of a bloodshot eye, as this can signify inflammation or infection and could potentially be a contraindication to an ophthalmic block. Also look to see if the patient has a pterygium. These are relatively common and related to sun exposure. They are benign, wedge-shaped growths of conjunctiva across the cornea, and they can cause irritation and redness, and potentially grow across the central vision. These can be difficult to dissect through and can bleed when performing subtenon local anesthesia. Next, we will look at the orbital contents, focusing on the extraocular muscles, the nerves and blood vessels that pass through the orbit, and finally the fat and connective tissue. This is an anatomical dissection showing a horizontal section through the orbit. We can see the optic nerve, the medial wall of the orbit, the medial rectus muscle, the lateral rectus muscle, the lateral wall of the orbit, and the orbital fat. We will now look at some of these items in more detail. We will start by looking at the extraocular muscles. There are 4 recti muscles: the superior rectus, the medial rectus, the lateral rectus, and the inferior rectus. These 4 muscles control the main movement of the eye. In addition, there are 2 weaker oblique muscles, the superior oblique and the inferior oblique, that fine-tune the movements of the eyes. These muscles, together with their associated connective tissue, form a cone around the eye. Understanding this is important when considering local anesthetic blocks, and will be covered in more detail in later sections of this course. But essentially, retrobulbar and subtenon blocks aim to place the local anesthetic inside the cone of muscles, and peribulbar blocks look to place the local anesthetic outside the cone. And now some clinical notes about the extraocular muscles. You must always avoid using the compass points, that is, north, south, east and west, for your dissection when performing a subtenon block, as you will risk damaging the main recti muscles. The superior oblique muscle, that provides around 15 degrees of torsion of the eye and a little inward movement, is also the hardest to block with subtenon and retrobulbar blocks, as the 4th, or trochlear nerve, that provides innervation to this muscle, lies outside the muscle cone. Now we will look at the sensory innervation of the eye. This is provided by the trigeminal nerve, with the main innervation coming from the ophthalmic branch, with the lacrimal branch of this nerve innervating the conjunctiva, the nasociliary branch, the cornea, sclera, iris, and ciliary body, and the frontal nerve, the forehead above the eye. In addition, the maxillary branch, via the infraorbital nerve, supplies the inferior lid, nose, cheek, and upper lid. Finally, the optic nerve, which supplies vision, but not direct pain innervation. When we perform an ophthalmic local anesthetic block, we need to provide analgesia, and to do this, we need to block the sensory nerves. Pain fibers are usually blocked first, as they are the smallest nerves. This is why pain relief after a subtenon block happens within the first 30 seconds. Pressure and touch sensation can take longer or even be preserved, as these nerves are larger. And finally, vision is often preserved, although usually reduced, as the optic nerve is the largest nerve and hence local anesthetic penetration is slowest or incomplete. The motor innervation of the eye is provided by the fourth, or trochlear nerve, that supplies just the superior oblique muscle, the sixth, or abducens nerve, that supplies just the lateral rectus muscle, and the third, or oculomotor nerve, that supplies all the other muscles. A way of remembering this is by using the made-up formula LR6, SO4, REM3. In other words, lateral rectus, sixth nerve, superior oblique, fourth nerve, and the remainder, the third nerve. We have already said that sensory pain relief following a local anesthetic block is rapid, and in general this is determined by the concentration of the anesthetic agent used. In order to get a good motor block, you will need more volume of local anesthetic in order to get penetration and coverage. The fourth nerve lies near the orbital apex and outside the muscle cone, which means it is often not blocked by subtenon and, to a lesser degree, retrobulbar blocks. But the limited functionality of the superior oblique muscle that it supplies rarely causes any issues. We will now look at the blood vessels supplying the eye and the orbit. The arterial supply to the eye and orbit is provided by the ophthalmic artery. This is the first branch of the internal carotid artery and comes off distal to the cavernous sinus. It has multiple branches that supply the orbit, the meninges surrounding the optic nerve, the face, and the upper nose. Technically, the ophthalmic artery is an end artery. That means that there is no collateral supply, so that occlusion of this major artery will lead to ischemia, and in particular, loss of vision. The venous drainage of the eye and orbit is supplied primarily by the vortex veins and the central retinal vein. These veins then merge with the superior and inferior ophthalmic veins and drain into the cavernous sinus, the pterygoid venous plexus, and the facial vein. Arteries and veins can be directly damaged by sharp needle blocks, leading to retrobulbar hemorrhage that is a potentially sight-threatening complication of these blocks. Direct arterial damage does not happen with subtenon blocks, but it is possible to damage the vortex veins as they pass through the subtenon space, and these can be damaged during initial dissection or cannula placement. It is worth noting that there is substantial anatomical variation in the location of these veins, so it is not possible to know their exact location in any particular patient. Although bleeding from vortex veins can look dramatic, it is not a sight-threatening complication and usually resolves within 1 week. But severe bleeding may lead to postponement of surgery, as it can make the surgery itself too difficult. Periorbital fat fills much of the remaining space within the orbit. This fat atrophies as we age and is why eyes can appear more sunken in the elderly. In addition to the fat, the orbit contains the eye or globe, which we will cover next, the lacrimal apparatus, the ciliary ganglion, which is effectively the junction box for the sensory innervation of the eye, and the fibrous tissue that supports the eye. In this last section, we will talk about the eye or the globe. The eye consists of three distinct layers. From superficial to deep, these are the outer, fibrous layer consisting of the sclera and cornea. The sclera is an opaque layer that surrounds the posterior 5/6 of the globe. The cornea is a transparent layer that is continuous with the sclera and covers the anterior 1/6 of the eyeball. Tenon's capsule is a thin fascial sheath that surrounds the eyeball. It separates it from the orbital fat. The inner surface of this capsule is smooth and shiny, and there is a potential subtenon or episcleral space that separates the capsule from the outer surface of the sclera. The junction between the cornea and the sclera is called the limbus, and this limbus is a reference point and also marks where Tenon's fascia and conjunctiva originate on the sclera. The outer layer of the eye is very hard to breach with blunt objects, but easy to penetrate with a sharp cutting needle, which is why globe perforation is a risk with sharp needle blocks, but not with subtenon blocks. A particular point to note with the outer surface of the eye is the presence of a staphyloma. A staphyloma is an abnormal protrusion of the uveal tissue through a weak point in the eyeball. It appears generally black in color due to the inner layers of the eye being visible, and occurs due to a weakening in the outer layer, commonly caused by severe myopia or inflammatory or degenerative conditions. The cornea is not covered by Tenon's fascia or the conjunctiva. The corneal epithelium, that is, the outer surface layer of cells covering the cornea, is very vulnerable to damage. A corneal abrasion can be very painful, and if severe, can lead to a visible scar. The next layer of the eye is the middle or vascular layer, which is also known as the uvea or uveal tract. This consists of three parts that are continuous with each other, and from posterior to anterior they are the choroid, the ciliary body, and the iris. In more detail, this middle layer has a distinct vascular component, the choroid, which is rich in blood vessels and melanin and is vital for retinal function, and a muscular component comprising of the iris that controls the amount of light passing through the lens and hence to the retina, the ciliary body that consists of the ciliary muscle and the ciliary processes, and the lens that sits in a natural capsular bag supported by ciliary ligaments. Contraction of the ciliary muscle alters the shape of the lens and hence allows accommodation of vision, that is, the ability to focus on both. Epinephrine drops are frequently used to reduce redness or bleeding during both surgery or local anesthetic blocks. In general, epinephrine drops cause no issues, but they can cause dilation of the iris, and this dilation can cause narrowing of the drainage angle in the anterior chamber and lead to an increase in the intraocular pressure. This increase in intraocular pressure can cause problems in patients with known angle closure glaucoma or in some glaucoma operations. If this happens, it can be reversed if required with pilocarpine eye drops. Lastly, we have the inner nervous layer, which is also known as the retina. This is the innermost layer of the eyeball. The retina is divided into two distinct layers, an outer, pigmented layer, and an inner, neurosensory layer. The inner, neurosensory layer contains rods and cones, and also the macula, which is the area of the retina where detailed vision occurs. In this section, we have covered the essential anatomy of the eye and orbit. It is not intended to be an exhaustive anatomy module, but rather to focus on the key areas that we need to understand as anesthesiologists. This module will also give essential background needed later in this course when we talk about local anesthetic blocks.